I do not think that the majority of abuse is happening by bad people who are criminals. In fact, it's quite the opposite. The vast majority is happening by people who are very well-meaning and really care, but just get to a point where they lose it.
From the USC Leonard Davis School of Gerontology, this is Lessons in Lifespan Health, a podcast about the science and scientists improving how we live and age. I'm Orly Bellman, Chief Communications Officer. On today's episode, how Dr. Laura Mosqueda is raising awareness about the issue of elder abuse and shaping how it is addressed in medical schools, clinics, and the national conversation. Dr. Laura Mosqueda is Dean of the Keck School of Medicine of USC and a professor of family medicine, geriatrics, and gerontology. She is a leading expert on elder abuse, a problem that is believed to impact 1 in 6 older adults around the world. She recently sat down with me to discuss this issue, as well as the importance of providing a holistic approach to family medicine, particularly when treating older adults. She started by explaining how the concept of lifespan health informs how she interacts with her patients.
Well, it's great for me as a family physician to think about lifespan health because we really do everything from delivering babies to helping people when they're at the end of life. So lifespan is near and dear to my heart as a family physician. As a geriatrician, it means a lot to me as well because we think about healthy aging as well as what it's like to age with chronic illnesses and very difficult illnesses like Alzheimer's disease and other dementias. The other thing I think that's important about lifespan health is the holistic approach that I think we tend to take when we think about lifespan, because it not only deals with the person themselves, but their whole family and social support network.
So that's an interesting thing because I don't know that people usually think about that when they're going to the doctor, you think you're getting your heart checked, your parts checked, but you're talking about issues that can affect your health that has to do with so much else. Can you talk a little bit about that?
I think one of the important things as a primary care physician is that we do take a holistic approach to things. So that sometimes I joke around with my patients and I say, well, your cardiologist's job is to pay attention to your heart, and my job is to make sure that we remember the heart is attached to the rest of you. And how are we going to take care of your heart in the context of you? And then even as importantly, in the context of your family and your social situation. So I can have 2 people who have the exact same problem, say, or severe arthritis of their knee. And their approach to care might be very different because of their social situation. So just as an example of what I mean by that, there might be some people who will want to have knee replacement surgery at the earliest possible stage that it makes sense. Because of their life's goals and what's important to them and what's meaningful to them. Say, hiking in the Sierras is really important to them. Whereas I might have somebody else with the exact same age, the exact same degree of osteoarthritis, degenerative joint disease in their knee, who is scared to death of surgery because their sister died when she was getting what seemed like, quote, routine surgery, and they're absolutely terrified by the thought. Or they have no family support that once they have surgery for their recovery. So that's why it's really important to understand people in the context of their whole body and of their whole situation.
And one of your areas of expertise is family violence. And how did that come to be something that you became aware of in the exam room?
Well, as a geriatrician, I was doing a 2-year fellowship to specialize in geriatric medicine. And I had a patient who came in and had a large welt on her arm. And when I asked her what happened, she said that her daughter had hit her. And that was the first time I ever encountered anything like that. So I went through the process of contacting Adult Protective Services. Lots of people are familiar with Child Protective Services when we have concerns about child abuse, but there's also something called Adult Protective Services. And I realized that we really have very poor systems in place, and that a part of the reason we don't have good systems in place is that physicians and other people in healthcare haven't really paid enough attention to elder abuse issues and partnered with our social service agencies well. And that really set my whole research career running. And it changed the way I practiced medicine too, made me acutely aware that older adults not only can be abused, are abused and neglected at astonishingly high rates, and that there's a lot we can do to prevent it and detect it at early stages.
So when you were in medical school and in your training, did anyone ever talk about elder abuse?
Never even heard the term elder abuse when I was in training. And now I'm proud to say here at Keck, all of our medical students get a lecture from me on elder abuse. And we put it in the context of family violence. So it's the same week that they're hearing about child abuse and domestic violence that they get a lecture on elder abuse as well.
I read that you not only, when you became aware of elder abuse and you contacted Adult Protective Services, can you tell me a little bit about what else you did, either in your research or practice? It sounds like you were going out on calls with them, and how did that all happen?
Well, the first thing I did when Adult Protective Services didn't do what I thought my patient needed is I marched in there pretty self-righteously and started talking to the social workers there. And that's when I really learned about all the limitations that they're under. And they started helping educate me about what reasonable expectations are and what is really needed in the healthcare system. That then led when I went to University of California, Irvine, where I was for about 14 years. When I landed there, I immediately went to the head of Adult Protective Services, a woman named Rebecca Geider, and I said, "Hi, I'm a new geriatrician here at UC Irvine. I'm really interested in elder abuse, and I'd like to partner with you, and I'd like to go on house calls to learn more." And they were so welcoming and kind, and I just started going out on house calls with Adult Protective Service workers to understand what it was they were seeing and to understand what we needed to do in the healthcare system to be better partners and take better care of these very vulnerable older adults. That then helped me set an agenda both for research as well as for what sort of new systems need to be put in place to address this issue. And I'll just give you two examples of that. One was I started going on house calls, and we would see somebody who perhaps had Alzheimer's disease and couldn't explain what happened to them, and they would be horribly bruised. Or we would see somebody who could talk about what was happening, and they were horribly bruised, but they seemed quite fearful. And we would say, "Well, how did you get all that bruising?" And they would kind of hesitantly say, well, I fell." And I was sitting there going, I've seen a lot of people who've fallen. I've never seen bruising like that. And I started thinking, some of these people are getting beaten. So then the question is, what was it triggering in my brain to say that wasn't just a fall? Or that person with Alzheimer's disease can't tell us what's going on, but all that bruising doesn't make sense. So we then designed some studies to begin to understand, when is bruising a forensic marker of abuse versus accidental? What are some of the things that might tell us and help us distinguish between accidental bruising and bruising that is more likely to be related to an abusive situation? And we really, as a team, published some of the landmark studies. I think one of the important points of this from any academic institution is then don't let that important information just sit in a journal that 4 people are going to read, but make sure it gets into relevant textbooks, make sure it gets into training for paramedics, emergency room nurses, et cetera. So we worked very hard at making sure the information got disseminated widely so that it really is getting utilized. So I was very pleased when I was taking my board exams in family medicine a few years ago, and there was a question on my board exam related to when bruising in older adults might be a marker of abuse. Pretty sure I got the answer right. At least I hope I did.
I feel like people know with child abuse that emergency room doctors and pediatricians know to look for. I've had friends whose kids slipped out of a high chair and then the doctor kind of looks at them funny, are you sure that's what happened? But that was not happening in geriatrics?
Yeah, it was not happening in geriatrics. And what's interesting, when you see an older adult, we expect older adults to get broken bones because, after all, they have osteoporosis, right? They've got low bone density. We expect older adults to have bruising because older adults do bruise more easily, or they're on a medication that prolongs their bleeding time to prevent a stroke or something like that. Or we expect older adults to fall because that's what older adults do. So whenever an older adult comes into an emergency room or a primary care office with some sort of injury or wound, we almost always can find a reason other than abuse or neglect that it happens. So unless we have the possibility of abuse or neglect on our radar, and what we talk about in medicine is we talk about a differential diagnosis. So unless we have that as a possibility in our differential diagnosis, we'll never think about it. So we don't want to overcall it and overaccuse people, but we need to be aware that it's a possibility. Just as a quick analogy, when an older adult comes in and has chest pain, we need to figure out, when we talk about our differential diagnosis, are they having a heart attack, or did they pull a muscle, or do they have pneumonia? So that's on our list of differential diagnoses. And if we don't have that list running through our brains, we'll miss something important. And the same is true when we see somebody who has a wound.
And did you, in your research and in implementing guidelines and practices, did you gain any knowledge from what was going on in pediatrics or with child abuse?
I spent a lot of time working with child abuse experts when we were setting up our systems. We started the nation's first elder abuse forensic center when I was in Orange County, California. And that was really based on the work being done in child abuse. I saw some of the centers they had put together. In that process, then, I also learned where they were in their research and how they were translating research into policy. And that was everything from how to investigate child deaths to wounds and markers, et cetera. But again, people don't expect children to die. We do expect old people to die. And so some of the ageist attitudes in our society have been a barrier to, I would say, the interest in understanding and diagnosing elder abuse.
What about nationally trends? Are you seeing an impact of your work? Are the forensic center models spreading, or is elder abuse going up, going down?
It's really hard to know on a national basis what's going on with elder abuse. The forensic center model is spreading, whether people call it advanced multidisciplinary teams or whatever the term might be used, but they really are spreading all over the country. It was written into federal legislation when the Elder Justice Act was passed. There's remarkable work being done, particularly in New York State, related to these sorts of teams. So we do see it spreading. Anecdotally, there's lots of good stories, but we need good research. We don't want to just be putting a lot of money into these sorts of teams without knowing what the outcomes are, but it's very hard to measure the outcomes. It's very hard to have a randomized controlled trial. And I think a good argument can be made that maybe that's not the right approach. There's other kinds of methodology being used now, like there's one that's called goal attainment scaling, where we're looking at individual goals and whether these teams help meet those goals. You know, my goal as a physician might be to keep this older adult safe, but what's the older adult's goals? Maybe they would rather stay at home and be abused than be kept safe and not be in their own home. How do we figure all of that out? The other piece relates to just collecting data. Every state has a different law related to elder abuse. And so you can't collect information across states and combine it. There's just now we're in the very early stages of a national database project, but it'll be years before we're able to really look at valid and reliable information on a national basis related to elder abuse.
And it sounds like it's something that wasn't even tracked earlier.
Exactly right. It wasn't tracked earlier, so it's hard to get a baseline. The other question is, if we see reports going up, is that good or bad? You could argue it's bad because it means there's more abuse happening, but you could also argue it's good because now we're identifying it more and we've been missing it. I don't know where the truth is. What I do know, one particular area of interest for me is what happens to people with dementing illnesses. And we know that people with dementia are particularly susceptible to being abused and neglected. And we certainly have a lot of good demographic information showing that the number of people with dementing illnesses is rising at a very rapid rate in this country. So one could only logically assume that the abuse and neglect will be as well.
So are there things that people either can know to look for if they think someone might be being abused, or if they're a caregiver, how can they make sure that they don't fall into either unintentional abuse or keeping their kind of emotions in check in what can be a challenging situation?
There's remarkable work being done to help caregivers and this idea of caregiver stress. It's so important for caregivers who are under stress to recognize that within themselves, to not feel embarrassed or ashamed, and to reach out and accept help, which is very hard for a lot of us to do. I was a caregiver. I took care of my mother for many, many years. When she had a dementing illness, she continued to live with my father. He was amazing. I and my husband were over there very frequently, so I understand what it's like. It made me a better doctor, and I remember sometimes I used to sit with her, even when I don't think she could understand me, and say, boy, Mom, this is a really rough way to make me a better doctor, but thank you. In recognizing when I was getting stressed, or my husband or my father, that we were there to help each other. But not all caregivers have the luxury and the wonderfulness of having a supportive family around. I knew that even though my brother didn't live close by, if things were really getting stressful, I could say, you know what, I need a break. And he would be here and spend a week. And even under those great circumstances, how difficult it was. So I think the message to caregivers is ask for help. You'd be surprised at how many people are willing. And groups like the Alzheimer's Association now have classes like the Savvy Caregiver, where they talk about stress, they talk about the potential for abuse, and how to prevent that from happening. I do not think that the majority of abuse is happening by bad people who are criminals. In fact, it's quite the opposite. The vast majority is happening by people who are very well-meaning and really care, but just get to a point where they lose it. I don't know if we'll get to a point where we can use things like biofeedback, look at stress hormones and say you're at high risk, your cortisol level is really high, or whether we'll be able to look at sleep patterns and say you're not sleeping well, give people feedback when their pulse, when their heart rate is going up, and say, you may not realize it, but we have evidence based on your biology that your stress level's going up. That puts you at risk of being abusive. So what can we do to dial that back? I think there's lots of things we can look toward that might help on the prevention strategy side of things.
And is it a challenge to get young people, when you see medical students, I guess they'll be starting again soon, to get them interested in older adults or in family medicine in general? I know those are specialties that are not as popular for current medical students.
Yeah, it is very hard to get physicians and other healthcare professionals interested in older adults. It's not the most sexy of topics. You know, you're not, one of my big jokes is nobody has ever thanked me for preventing their fall. If you go into oncology, it's a very heroic sort of specialty, and cardiothoracic surgery is very heroic. Geriatrics is not what you think of when you think of a heroic specialty. So it just doesn't have the same kind of oomph and excitement that other specialties do. But once you get in there and you do some house calls and you meet people who are 90 or 100 years old and hear their stories, for me, that's very inspiring. And many students, many people in their 20s typically haven't necessarily grown up with grandparents these days, have had very little exposure to older adults. They view older adults as really a very foreign concept. They're like an alien species. They're not used to What do you do with somebody who has a dementing illness? And because I think as a society we tend to devalue older adults and make fun of older adults, that often is how people in their 20s view aging. And the other piece of it is we tend to be afraid of aging. We see ourselves in people who in their 80s and 90s, and that can be very frightening. So gaining those sorts of insights can, I think, sometimes make people a little less fearful. And perhaps it's a way that we here at USC can start introducing medical students into the wonderfulness of going into geriatrics and caring for older adults.
What are some reasons we should not be afraid of aging?
Well, one reason to not be afraid of aging is you better hope you get there. So how are you going to make the most of it? We tend to focus on the negative aspects, and I understand that. It is not for sissies. It really is often very difficult, lots of things to cope with. But if we think about also some of the wonderful things that happen with aging, the deepening of the relationships that we have, the meaning that we can find in life, that we can reflect back on as we get older, the influence that we can have on younger generations, the joy that we can still derive, the joy that we can provide for others. I think all of those things really deepen our understanding of the importance of our lives and deepen our understanding of the meaning that we have not only for ourselves but for the others around us. That truly older adults help make the world a better place.
That wraps up this lesson in lifespan health. I'd like to thank Dean Laura Mosqueda for her time and expertise, and all of you for choosing to listen. Please subscribe to our podcast and learn more about us at lifespanhealth.usc.edu.